afternoon, depending on where you are, and welcome again to this webinar series for Latin America and the Caribbean, focusing on nutrition in emergencies in the context of COVID-19 and migration. So today is the last webinar of this webinar series, and that will be on nutrition care for children under 5 with acute malnutrition. So I introduce myself, although you already know me. I am Yvette Pouch, nutrition specialist at UNICEF Regional Office for Latin America and the Caribbean, based in Panama. Caroline de Hillary will be another, the other facilitator, the co-facilitator. She's a family physician and public health specialist. She works at Save the Children and she's based in Bolivia. We will also have Geraldine Belloc and Belle Allen from the Global Nutrition Cluster Technical Alliance as technical support. So before starting, I would like to remind you of some of the elements of the management of this webinar. So first of all, we are recording the webinar. So any intervention you do in the chat or in the questions and answers will be recorded. We will also have an evaluation of knowledge in 2 times. So at the beginning of the webinar and at the end. That will be confidential, so we will not know your specific responses. So please feel free to participate. We will at the end have a session on questions and answers. If you have a specific question, please use the Q&A option in Zoom. And well, don't use the chat, just use the chat to introduce you. So your name, your organization, your title, etc., so that we know who's participating in this webinar. And finally, at the end of the webinar, we'll have the evaluation of the webinar. So that would be useful for us to know any recommendations from you on how we can improve our webinars. And I give the floor now to my colleague, Caroline.
Thank you, Yvette. Good morning, good afternoon, everybody. We will start, as we've done in the previous webinars, with a poll. That is the pre-test. Please launch the poll if you can, Geraldine, and take your time for your answers. We have another half a minute. Please answer the poll. Okay, I will stop the poll now. Unfortunately, we only have 19 of the 24 people who have filled it out, but that's okay. As always, I will share the results without commenting them, so that we can take note. The first question. Second question, and we hope that all of these questions become clear through the webinar. And then at the end, you will have a chance to repeat the poll again with the same questions. And obviously you can change your answers if you think that now you think something else is true. Okay. And I'll go right into the webinar. The content for today is I'm going to be talking about acute malnutrition or wasting, what it is, why it is important to identify it, and what are the causal factors, and most of all, how to determine if a child has acute malnutrition. And then my colleague Yvette will be talking about the basics of community management of acute malnutrition and what is now called simplified approaches to that community management. At the end of the presentation, she will also take you through a couple of resources that are available online for further lecture and reference. Next slide. So we'll go into acute malnutrition and wasting. This is, we've shown this slide in previous webinars, UNICEF conceptual framework of malnutrition. You see at the center there, maternal and child malnutrition are both caused by inadequate dietary intake in relation to diseases. And then there are underlying causes that are basically at the household level, and what they call basic causes that are at the society level. I won't go into more detail. Next slide. So what is acute malnutrition? It's a form of undernutrition, so lack of nutrition, therefore it's called under, caused by a decrease in food consumption and or an illness. And those factors result in a sudden, more or less sudden weight loss or edema, so retention of fluid. Acute malnutrition, that's important, can be either moderate or severe. The word acute does not mean that it is severe. Acute refers to the fact that it has happened in a relatively short time. A child with acute malnutrition has an increased susceptibility to infections and to the severity of illness. So this kid over there, if it gets pneumonia, it will probably get it more severely than a child with good nutritional status. And the last one. Right, next slide. So there is a vicious cycle, and the kid can either start with the undernutrition because there was no food, and then it decreases immunity, has an increased risk of disease, and gets an infectious disease. And then because of the infectious disease, it has increased energy needs. And those increased energy needs are because the child is losing its appetite when it's sick, especially when they have fever. It decreases its nutrient absorption. So although it's eating, the nutrients don't pass from the intestine into the bloodstream for a number of reasons. And it needs more calories to fight the infection. So all of that causes that, again, it's losing weight and there's undernutrition. So a child can either start with the undernutrition and then go through this vicious cycle, or it could also have started with the infectious diseases. It doesn't really matter where the entry point is, but the effect is the same vicious cycle. Next slide. So that's the same thing as we've been talking about. And below you see there is an increased risk of death due to infectious diseases. And that is why acute malnutrition is such an important health problem, because many of these children can actually die. Next slide. So here you have some data from the Lancet series of 2013. Why is it important to identify acute malnutrition? Because of the increased probability of death due to infectious diseases. And what you can see here is that the lowest row is for children with a normal nutritional status, which is weight here measured as weight for height over -1 standard deviation. Sorry for that, it shouldn't say DE, it should say SD. So all of those are calculated as 1, which means it's the normal probability of death. And then you can see as you go up that if the child has a normal nutritional status but is a little bit slimmer, which is -2 to -1, it already increases the probability of death, 1.6. If the kid is moderately malnourished, it increases to 3.4. And then you can see sort of a jump. If you go to severe acute malnutrition, which is the line up on top with the numbers on red, it jumps up to 11.6 odds ratio of dying. That is for all deaths. In the case of pneumonia, it's 9.7. Death due to diarrhea jumps up to 12.3. That's tremendous. That's like 12 times as many children who are in that group. They will have a probability 12 times higher. And in deaths to other infections, it's 11.2. Those are particular malaria, other tropical infections, parasitosis and other tropical diseases. So you can see that particularly the children with severe acute malnutrition have a much higher death risk than their normal peers. And that is why it is so important to identify them. Next slide. So the causes of acute malnutrition, we've talked a little bit about it while we were talking about the vicious cycle. It could be inadequate dietary intake. There can be inappropriate feeding practices in the home. Last week, we talked about infant and young child feeding and how difficult it is sometimes to make these kids eat. The child could have started out already with a fetal growth restriction while it was unborn, and therefore has, when it was born, it was small for gestational age. But there are other factors in the home, such as inadequate sanitation because of the fecal contamination of either water or the soil where the child is living. It can be a lack of parental education. The family size can be a matter if there are so many children that are all struggling for food. Incomplete vaccination has been related to acute malnutrition. And then those general factors for the family, such as poverty, economic, political, and environmental instability, and particularly emergency situations, can cause acute malnutrition in children, particularly under 5 or under 2. Let's go to the next slide. So within the COVID context, the situation still worsens. On top of all of these, we have, due to lockdown and quarantine, in poor families, we have a loss of employment and income, and that results in a reduced economic access to food. And then we also have the disruption of health services that are either have been closed or severely limited, and that people are not accessing them anymore. And that contributes to that risk of acute malnutrition. Next slide. So now I'll go into how do you determine if a child has acute malnutrition. And it's very important that you understand that we're talking about 3 different and independent criteria here. The first criteria is what we've been using for many years now in most health services, which is anthropometry by weight and height. The second one is also anthropometry, but it's called the mid-upper arm circumference. And the third criteria is edema testing, and I'll go into each one of those. Next slide. So weight for height is typically evaluated by looking at these curves where you plot the weight for the child by its height. And you look at where the little points of that kid falls into, and then you look at it in terms of these curves. And you can see that below the last line is -3 standard deviations. Any child that falls below that is considered severely acute malnutrition, or SAM. And the kids between line -2 and line -3 are considered MAM, or moderate acute malnutrition. The kids that are in any of those where the green arrow is, so on top of -2 and up to +2, are considered normal. And then those that are between 2 and 3 would be considered overweight. And those that are above 3 would be considered obese. But here in this webinar, we're talking about acute malnutrition. So we're looking at the lower end of the spectrum. These weight for height graphs or tables have been maintained. They've been launched in around 2000. They are based on WHO criteria, and they are accepted basically all over the world. Next slide. So what do you need if you're going to go and measure weight for height? Well, you need a scale, and we typically recommend now digital scales that are mother-child scales. So the mom, as you see in the picture, has the baby, and then somebody else holds the baby, and the mother is measured again, and then the scale gives you automatically the difference, which is the weight of the child. You have to remember, obviously, to undress the child, and it shouldn't, the diaper shouldn't be full, because that could influence, obviously, the weight. Then you need height boards. You need height boards that work for children who can stand up, with those who are 2 years old or older, and also those that can be lie down on a table, as you can see, for children who are under 2 years of age. The most important is that you need trained staff and what we call standardized. So you do a certain statistical analysis and train people until you get measurements that are pretty precise. Because it's still difficult to actually get a good height measurement, particularly length of a baby which is lying down on a height board. And as we are now in COVID times, the staff that does that needs personal protective equipment. Next slide. So what about the COVID context? As I said, for weight, you need a digital scale, and you can see in where it says recommended during COVID-19, digital scales, yes, are recommended because they're safe, because basically the adult is standing on the scale, doesn't need to take their shoes off, can just step on it, but because there's no need to touch anything, there's no button. On the other hand, if your health service is using an infant scale, the infant is placed on the surface, and that surface could be contaminated. So in COVID context, we don't recommend the use of an infant scale. Next slide. So what about the height boards? They are obviously difficult to replace. There is no currently available technology. They're working on some stuff where you wouldn't need a height board anymore, but it's not yet disseminated to the public. So the recommendation is that, yes, you can use a height board, but only if your infection and prevention control protocol is in place and your personal protection equipment is available. As it says here in the middle, their height is measured, standing up, upright, or lying down. And the caregiver is usually requested to help keep the head of the child straight. And both the child and the mother are in contact with a surface. So additionally to personal protection equipment, the height board should be disinfected after every use. Next slide. So now we go into the mid-upper arm circumference. That is also an anthropometric procedure, because you're measuring something from the body. The MUAC measurement is an indicator for acute malnutrition. It's measured with a strip, which is a flexible measurement band, which indicates millimeters and centimeters. MUAC should only be used in children 6 to 59 months. So those measurement indicators that you see here with the colors in red, yellow, and green only hold true for children 6 to 59 months. Older children, we use other thresholds, and in younger children, it's also not, those are not the thresholds, and we don't recommend MUAC for those ages. As you can see, there's a little measurement window and a slip to insert the strip into, so that the measurement, that you can see exactly where the little arrows are. That's the point that you need to measure. Next slide. Well, there were a couple of questions about measuring MUAC. As you can see, so first, the child's arm is measured, the length of the upper arm from the shoulder to the elbow. When you're doing that, the arm of the kid is usually held at 90 degrees so that you can feel exactly where the elbow is. Then you have to calculate the middle of that, mark it with a pen, and then you apply the MUAC for measurement. And as you can see, the person who actually does the reading is in the back of the child, not in the front. Next slide. So here you get a little bit more detail. The first picture shows that the person is feeling where the shoulder bone is, and then the elbow bone, the epicondylus, and then calculating with it where you see that little arrow, calculating halfway, and then that's going to get marked. And then the kid is relaxing her arm, as you can see in the second picture, and the person who reads off the MUAC strip is reading exactly where does it fall with the little arrows. Next slide. So children who have a MUAC reading of over 12.5 don't have acute malnutrition. I repeat that this is for acute. The child could have other forms of malnutrition, such as chronic malnutrition or micronutrient deficiency. It could be anemic, but it doesn't have acute malnutrition if the MUAC is in green. For moderate acute malnutrition, it's between 11.5 and 12.5. And for severe acute malnutrition, it's under 11.5 or 115 millimeters. To facilitate the reading, the MUAC strips now come with these colors, green, yellow, and red. And yellow and red indicate acute malnutrition by degree. Next slide. So this is an article which has appeared in 2016 about whether we should recognize MUAC, mid-upper arm circumference, as a criterion for diagnosis of acute malnutrition, and the simple answer is yes. It says here, all studies that have examined the relationship between anthropometry and mortality in representative population samples have consistently showed that MUAC is more sensitive at high specificity levels than compared to weight for height Z-scores, which was the curve that I was showing you earlier, for identifying children at high risk of death. So it's MUAC is a very good diagnostic tool. And the second point is that children identified as severe acute malnutrition cases by low MUAC gain both weight and MUAC in response to treatment. The widespread use of MUAC has brought enormous benefit in terms of coverage and efficiency of programs. So not only can you use it to screen children and find those that are malnourished, but you can also use it to do follow-up of those children who are in treatment and who are, getting whatever the treatment is, and you want to see whether they're improving. And then it says, as a large high-risk group responding to treatment, children with low MUAC should be regarded as a public health priority independently of their weight for height Z-score. Next slide. So what about MUAC in times of COVID? The assessment tool is just the tape. The risk of transmission, it does require a short-term but direct physical contact, as you've seen in the photos, between the child and the health worker, and a physical proximity between the health worker and the caregiver, and a contact with a surface, which is the MUAC tape. So it can be used only if the MUAC tape can either be disinfected after each use, or if a single-use MUAC tape is available, and if masks and gloves are available for health workers. We're going to go in, when we're going to talk about simplified approaches, we're going to speak about a little bit about family MUAC. So the tendency right now is to have a MUAC tape that stays with the family. So the first time you enter in contact, you give them the MUAC tape, and then they do the exam, and the health worker stands a little bit at more distance, and that also decreases the risk of COVID transmission. Next slide. So now we're going to go into the third way of finding out if a child has acute malnutrition. The first one was weight for height. The second one would be MUAC, and now we're going to go into edema testing. So what is edema? It's an unusual large quantity of liquid which accumulates in the child's tissue. The tissues fill with the liquid and look swollen. And how do you determine it? You have to use both thumbs, press on the upper part of both feet, sorry for that error, simultaneously for 3 seconds. So 1 second is as long as it takes you to say 1001. That's 1 second. So you say 1001, 1002, 1003, and then you take off your thumbs, and the child has edema if that dent or if the dent remains in the child's foot when you took away your thumbs. It is very important that you do it with both feet, because if the child only has a swelling in one foot, that could be due to another cause. The child could have been falling or had an insect bite, or scratched itself, and it became infected, and so one foot is swollen and the other one isn't. In that case, you don't count it. When we're talking about edema as a sign of malnutrition, we're always talking about bilateral on both feet. In any case, if you find edema in both feet, the child classifies as severe acute malnutrition. Next slide. So what about edema testing in COVID? As I said, the assessment tool is the physical exam of the child's feet. The risk of transmission, again, it requires a short-term but direct physical contact between the child and the health worker. And typically a proximity with the mother, because if it's a small child, it will be sitting in the mom's lap, or the father, or whoever is the caretaker in that moment. As said, the indicator is a sign of severe acute malnutrition and is highly related to the risk of mortality. So the current recommendation is that edema can be measured only if masks and gloves are available for health workers. But what it says in the yellow column is that if personal protection equipment is not available, this assessment can also be carried out by the caregiver. under the supervision of a health worker. Next slide. So this is kind of a summary. What are the criteria to determine the cases of acute malnutrition? You can either use weight by height, and in that case, the normal is -2 to +2 standard deviation. Moderate are -2 to -3 standard deviation on the curve, and the severe cases are the ones that fall below the curve of -3. Or you can use mid-upper arm circumference, and in that case you would have no acute malnutrition if it's over 12.5, moderate between 11.5 and 12.5, and severe if it's below 11.5. And the third criteria is if you do edema testing. In that case, you can't classify moderate or severe. In any case, if the child has bilateral edema in the feet, it's called severe acute malnutrition. Next slide. I'm going to talk shortly about the medical complications. The important thing is that the people who do screening, either in the home or in any type of community setting, will find children who classify as acutely malnourished children. And they need to find out which of these children are going to go directly to a hospital because they have a medical complication. They therefore need to be trained in finding out about medical complications. So one complication is anorexia, or not eating well, poor appetite, intractable vomiting, which is if the kid is vomiting everything that is either drinking or eating. Very high fever or very low body temperature, called hypothermia, is an important sign of medical complication. Lower respiratory tract infections, typically pneumonia, is defined as a cough with difficult breathing, which we can see by chest indrawing, or very fast breathing, and you get the numbers of breathings per minute that we use to do that diagnostic. The child could have severe anemia, which means that the palm of the hands are extremely pallid compared to other children. It could have skin lesions, broken skin, fissures, or flakings. Very important are neurological symptoms such as unconsciousness, lethargy, or a lack of alertness. So if the child is very drowsy, doesn't watch the face of the mother when she's talking to him, or is unusually sleepy, that is a very dangerous sign. Hypoglycemia is very difficult to detect in the home because small children don't have a very strong symptoms. But if you see a kid that is sleeping with the eyes slightly open, that can be a sign of hypoglycemia. Convulsions, obviously, if the child has convulsions during this current illness, that is a danger sign. And severe dehydration, which can usually be because of a recent history of diarrhea, vomiting, or fever. Those are important signs, danger signs that require that the child has a medical complication and therefore needs to go to medical care. Next slide. So a summary, if we do screening, we're going to find 3 types of children that all of them have acute malnutrition. So the first one is acute malnutrition with complication. That is a child that has acute malnutrition, either severe or moderate, but it also has or can have edema, and has any of those signs that I've just explained: anorexia, lower respiratory tract infection, severe dehydration, severe anemia, or is not alert. Those are the children that are very much in danger of life and need to be referred immediately. Then you have a group of kids that have severe acute malnutrition, but no complications. So their weight for height is below the third standard deviations, or their MUAC is below 11.5, but they don't have edema, they have an appetite, they're clinically well, they look good, and they're alert. And you have children who have moderate acute malnutrition without complications. Moderate means their weight for height is between -3 or -2. Their MUAC is between 11.5 to 12.5. But again, those children don't have edema, their appetite is okay, they're clinically well and alert. These distinctions are important, particularly because the management, which my colleague Yvette will be talking about, is different. So those children with complications have to be going to hospital, whereas the children without complications can be managed at home. Next slide. And I'll hand over to Yvette.
Thank you very much, Caroline. Okay, now I'm going to present about the basics of community management of acute malnutrition. Okay, so the first thing we need to have to manage acute malnutrition in children under 5 is a protocol. So we need at the national level some guidelines about how to identify children, how to treat them, and how to do the follow-up. So this is the first important point, having a written guidelines. And we will see that there's in a few slides that there's a possibility to do a simplified protocol in the context of COVID-19. Another aspect that is very important to have is trained staff. So we need staff that knows what is acute malnutrition, knows the risks, knows how to identify acute malnutrition, as well as identify the medical complications. So this is, and of course, that can provide treatment until recovery. We also need that the staff is trained in monitoring and following up cases, so really recording, following up cases, and also where to refer children with medical complications, for example. Another important aspect is the need to have supplies for acute malnutrition management. So not only at anthropometric equipment, such as MUAC strips or weight and height equipment, but also the ready-to-use therapeutic food. So really nutrition supplies to treat acute malnutrition. And also it is suggested to have a referral system between different levels of the health system, in the sense that if a child with acute malnutrition is identified, let's say, at an outpatient clinic, this child needs to be referred to a hospital. We will look into that in a few slides. Okay, now a very important aspect now in the context of COVID-19 is the infection prevention and control measures that we need to take. That is, of course, hand washing and personal protection equipment, such as medical mask, eye protection, long sleeve and clean gown, and gloves. To the extent possible. Also respiratory hygiene, cleaning and disinfecting equipment and surfaces, and of course have a correct supply chain management that would avoid any risk of infection. Okay, so we have seen that for the identification of cases, there are three possibilities. It can be done with anthropometry or with the MWAC tape or testing edema. And it's important here that it's one or the other, in the sense that you can simply identify severe acute malnutrition by doing edema testing or using only MWAC. And it's also important to do an appetite test, and that this is positive, meaning that the child has appetite. Otherwise that would be a medical complication. We need to see if there are any medical complications in the child and that the child is conscious and alert. So when we have these elements, so it's possible to manage acute malnutrition at the community level. So here we stress this point that these are independent criteria for admission to treatment of acute malnutrition. We often see in countries that the MWAC tape is not recognized and that children referred with using the MWAC measurement to clinics where they are, the weight and height are measured, are then not admitted to treatment. So this is a WHO criteria. So this is very important. So children with low MWAC should also be admitted to treatment. Now, the referral of cases. So children with acute malnutrition without medical complications, who are the majority of them, 80 to 95% of them, can be treated in ambulatory health services, urban or rural. And also they can, well, at home, mobile clinic campaigns, and intramural. The idea here is to have this child really managed at the community level, in contrast to at the hospital level. However, children with acute malnutrition with medical complications, the ones that Caroline presented, that are a minority, should be referred to hospitals. And actually, children with acute malnutrition younger than 6 months of age should also be referred to hospitals. And there are some key, important elements of outpatient management of acute malnutrition. Now, this is a summary of a summary. So for details, you can go to WHO guidelines that we will see in the resources section. So this is a summary for you that we're presenting here, but look at the details in that manual. So one important aspect is nutrition management. The important thing here is to continue promoting and supporting breastfeeding. That is, of course, a safe food in this case. Also, it's important to provide RUTF, so ready-to-use therapeutic food, and address micronutrient deficiencies. So RUTF already contains micronutrients, so there is no need to, for example, provide vitamin A macrodoses, but we can provide in addition folic acid. And little by little, it's important to start family foods along with the recovery, and of course to conduct a periodic nutritional follow-up. Another important aspect is the medical management. So it's important to have a periodic medical examination and manage prophylactic infection for severe cases, do deworming and antimalarials, and of course vaccination. This is also key. Third component of outpatient management is complementary intervention. So sensory motor stimulation, so anything related to early child development, or to promote key practices, to provide additional food to the family. So that can be done, for example, with the food security sector. And of course, build capacities of community health workers. Now let's look at referral and treatment. Well, this is what was suggested also pre-COVID. So any child with complications, either MAM with moderate or severe acute malnutrition, should receive hospital treatment. And this is the therapeutic formula, milk formula with which treatment is done. For children with no medical complications. So moderate acute malnutrition can be, we can use supplementation to treat it. So it was suggested to use ready-to-use supplementary food. Here we can see an example of Plumpy Sup. And for severe acute malnutrition cases, the product to use in ambulatory treatment is a ready-to-use therapeutic food. So here we can see a picture of Plumpy Nut. So these are the nutrition supplies used for the treatment. Now let's go into more detail to see the outpatient treatment of severe acute malnutrition. So the use of ready-to-use therapeutic food. So this is a ready-to-use and specially formulated pastes that provides high-quality protein, energy, and micronutrients. And this is a product that is more nutrient-dense than any available home foods. One sachet provides 500 kilocalories. An important aspect is that this does not require any preparation, any mixing with water or any other food. It has very low moisture content, and so it's resistant to microbes. And the way it is provided in treatment is that the amount of product is calculated based on the weight of the child. And it starts slowly with 100 kilocalories per kilogram per day, and it's increasing according to the severity of acute malnutrition. An important aspect of the community management of acute malnutrition is, of course, the follow-up. So we need to review the compliance with the management plan, conduct feeding recalls and evaluate family feeding practices, evaluate if the child has been ill in the last 2 weeks. Also, it's important to conduct a physical examination and detect any danger signs but also signs of recovery. To redo an appetite test, to test again for edema to see if there's bilateral edema, measuring weight, height, or MUAC, and of course, do more in-depth medical and nutritional evaluation as needed. The actions is to adjust the quantity of ready-to-use therapeutic food and also liquids, and strengthen family key practices and competencies. It's important to see any alert if for example, if there's no positive evolution in the following in two follow-up visits, if there is acute diarrhea, and if the mother or caretaker have any special needs. Okay, so this was a summary, of course, and there are many materials that you can consult for more details. But here we presented what was done in the pre-COVID era, let's say. Now we're going to present the simplified approaches to community management of acute malnutrition in the context of COVID-19. So here is a summary of programmatic adaptations that WHO and UNICEF recommend to lower the risk of infection. And of course, also to facilitate logistics in this context. So we're moving from having MUAC screening conducted by community health workers or any other staff, health staff. And now we're promoting that caregivers use MUAC to identify acute malnutrition in their own children. So the idea here is to train caregivers to use the MUAC tape. Also, the current treatment models propose two different, but also very similar products to treat severe acute malnutrition and moderate acute malnutrition. And now it is suggested to use one single product, so ready-to-use therapeutic food. So the one we saw in the previous slides, the red one. So to have one harmonized program. This is also to take into account all the logistical aspects that come with this in this context. And the current protocol or UTF dosage increases over the course of the treatment and is based on weight, as I just presented. Now we're moving to having 2 sachets per day for uncomplicated severe wasting, and 1 sachet per day for uncomplicated moderate wasting, so moderate acute malnutrition, as determined by MUAC or edema status, bilateral edema. So previously, the protocol calls for weekly follow-up visits for children receiving treatment. Now, it's recommended to reduce the follow-up visits, again, to reduce the contacts, and to reduce the follow-up visits to bi-weekly or monthly. And an important aspect here is that in these follow-up visits, the health professional, the community worker should provide enough product, enough RUTF, for example, for 4 weeks, for a month. Also, our admissions criteria that we have seen is either MUAC and or edema and or weight for height. Now, it is recommended to use only one criteria, which is the MUAC tape, to define and facilitate the enrollment and follow-up of children. And finally, before the treatment of children with uncomplicated acute malnutrition or wasting would take place in a health facility. So now we are promoting, WHO, UNICEF is promoting to empower community health workers to treat uncomplicated acute malnutrition in the communities. Now let's look a bit more at the family MUAC. So it's about empowering caregivers to identify acute malnutrition by using the MUAC tape. So actually mothers and other family members can do this task as effectively as community health workers, as we have seen in several experiences around the world. Also, malnutrition is detected earlier. So we ask the mother or the family member to measure the MUAC every week. And of course, if there's a problem, if the MUAC shows yellow or red measurement, they should be, the mother and baby should go to the health center. Also, there are less hospitalizations with family MUAC, and there's also potential to save money and time for health workers. And of course, it's a great initiative to support and empower the community. So there have been many experiences around the world, and we're providing the link to the resources and videos at the end of the presentation in the resources section. Also, to support this programmatic adaptation, WHO and UNICEF have adapted the MUAC tape for caregivers. So it's easier to use for caregivers. So it's now double-sided, and it has instructions on the reverse side to guide caregivers in monitoring their children at home. And now the MUAC tape can be printed locally. So here we can see this document is already ready to be printed locally. So there's no need to procure it overseas or in another country. It can be printed locally, and there are guidelines for that. Here, I just wanted to show the reverse of the MUAC tape that shows clear instructions for caregivers using also images. And well, now with simplified approaches, there are several expected positive outcomes of this. So an increased coverage, also increased early detection of children with acute malnutrition. So again, less severe cases. Also a decrease of defaulting amongst children enrolled in programs, a decreased cost per child cured, improved continuum of treatment, increase the capacity of health staff and management of acute malnutrition, increase integration of treatment into community health structures, and increase the integration of management of wasting into health systems. So the overall objective is to increase effectiveness and cost effectiveness of management of acute malnutrition, with the overall goal to contribute to reducing mortality and improve child development at the populational level. Now let's look a bit more into the migration context. So again, this is a summary of some ideas of what could be done at different points in the migration transit. So for example, at the borders, where sometimes there are shelters with refugees and migrants, it is important to early detect children under 5 with acute malnutrition and to give priority to children under 2 because they are, of course, more vulnerable. Also, it's important to, it is suggested to promote the use of family MOAC so that mothers and caregivers are empowered and trained to identify on their own signs of acute malnutrition. Also, it's important to empower community health workers to treat acute malnutrition, and it is suggested to use only a single criteria, so MOAC, for admission and discharge from therapeutic treatment. So here, weight and height in the context of COVID-19, the use of this anthropometric equipment is not really promoted. Concerning the treatment, again, it is suggested to adopt only one product for all children. And of course, to reduce the visits to health facility during the treatment, and also to reduce the contacts between health professionals and the mother and the family. Now, for migrants on the move or children on the move, it's a bit difficult, of course, to identify them and to treat them. But a possibility is to hand out at the border before they continue the transit, is to hand out MOAC strips to caregivers and train them to identify acute malnutrition with a MOAC strip. So at least they can do that weekly and then go to a health facility when the MOAC tape shows a yellow or a red color. And at the host community, it's the same, we're suggesting the same actions that at the shelter level. The difference is that in host communities, that would be done more in ambulatory or outpatient health services. Whereas at the border, this can be done, in mobile clinics, for example, where health centers may not be easily available or accessible. Okay, before doing anything, it's really important to review the existing protocol at the national level and to see what is currently being done and what is currently being in place. Some countries do not have any national protocol, and this is where it's important to develop a simplified protocol, or also called interim protocol, along the guidelines we just presented. So it's simplified. Now we're going to the resources. So an important resource here is a guideline produced by WHO in 2013 that provides the updates on the management of severe acute malnutrition. So this is a key document to consult when preparing a protocol to manage acute malnutrition. There's also this second manual produced by WHO and UNICEF in last year, and here you will find all the details of programmatic adaptations to conduct in the context of COVID-19. There's also a toolkit for community health workers for community management of uncomplicated wasting. So this can be used to train community health workers. There's also a guidance note produced by UNICEF on how to, of course, to print MOAC tapes locally and how to manage this new adaptation of MOAC tapes locally. There are also new MOAC tape specifications that you can access online, and actually you can download the file, the MOAC tape to print in different languages, including Spanish, French, English. So that's an important resource. And we're providing here many links to resources related to family MOAC. So here there are videos and also guidelines and experiences that you can look into. So this is all. And actually, I would like to thank several people who supported the development of this presentation, including Grace Funnell of UNICEF headquarters, Elena Rivero from the Global Nutrition Cluster Technical Alliance, and Sandra Estupiñán from UNICEF Colombia. And now I give the floor to Caroline to conduct the post-webinar evaluation.
Thank you, Yvette. Before we launch the poll again, I do want to emphasize one point that is part of the poll question that I hope has come through clearly. I'll just repeat it. So before COVID, the recommendation was to purchase RUTF or therapeutic food for SAM children with severe wasting, and RUSF, supplementary ready-to-use sachets for children with moderate wasting. The recommendation now is to just use therapeutic food, which is the plumpy nut, not the plumpy dose, and give children with moderate wasting 1 sachet per day, and children with severe wasting 2 sachets per day, independent of their weight. That is a new recommendation that has come out now because of the COVID crisis, which not only affects transmission and people dying and hospitals being full, but there are also a lot of logistic problems. And I think it is because of that this so-called Simplified protocol asks for country programs to just purchase one product. And if you can only purchase one, purchase RUTF. Okay, with that being hopefully clear, let's launch the poll. Geraldine, please. And everybody can participate. Those people who have entered the webinar now, after the pre-test, can still take the post-test. That's okay. So we're still on the poll. I see 19 of our 30 participants have answered. A couple of people more. Please put in your answers. Okay, I will stop the poll now. Thank you for those who filled it in. And I will go over the answers this time. We have still a bit of time left for this webinar. So the first question was, can the MUAC only be applied by a highly trained health staff? And most of you said that that's false, because it can be applied by a volunteer, it can be applied by the mom, it can be applied by any family member who has been trained, and it's not a difficult training. So it doesn't need to be highly trained, and it doesn't need to be health staff. What is true about applying the MUAC? The person who measures stands behind the child. I hope you all have seen this image that I showed. The person who reads off the measurement stands behind the child. You usually have a helper who stands in front of the child, but the person who reads it off should be behind the child. Obviously, it shouldn't be pressing the strap very tightly, because otherwise, you know, you will get a false measurement of acute malnutrition. Obviously, you shouldn't maintain your fingers under the strap, because you would get a false green measurement, because you're measuring your fingers. It measures the dominant arm of the child is wrong. And if possible, or if the child already has a preference, it should be measured in the non-dominant arm. And the arm of the child is folded when you're marking the measurement point, and then relaxed when you're actually measuring. That was the true answer. And we've got 83% of people got it right. The stuff about what happens with the kids with acute malnutrition or wasting, which is the same thing. A child without acute malnutrition does not need any supplement at all. That is wrong. And we've talked about supplements in the last webinar about infant and young child feeding. So we do give out supplements such as micronutrient powders to children who are not acutely malnourished, or are not malnourished at all. A child with acute malnutrition does, of course, need treatment. As I've shown, it has a higher mortality risk. A child with severe acute malnutrition but no complications must not be admitted to a hospital, because it doesn't have any complications. So that kid can be managed at home. A child with acute malnutrition and with complications must be admitted to a hospital. 83% of you got this right. And a child with chronic malnutrition must be admitted in a specialized center. That is not true. In some of the populations, particularly in Latin America, that would mean more than half of the entire population would have to be admitted to a hospital, and that's of course not possible. And there are other strategic elements that we recommend when stunting or chronic malnutrition is very high. So I'll go into the fourth question. That was about simplified approach. So all children with acute malnutrition receive 2 sachets of RUTF per day is wrong, because we'll come to that. Children with severe acute malnutrition with complications receive their RUTF 2 per day, plus more frequent follow-up controls. That is also wrong, as explained. Every time that you see a kid with complications, that kid should go to the hospital. Children with moderate acute malnutrition receive 1 sachet of RUTF per day. That is the correct answer. We have increased our correct answer from 37% to 48%. That means simplified approach. The number of sachets depends on the weight of the child, is not simplified approach. That was the approach before COVID. Now, because of the danger of weighing children or potential danger, we're not trying not to base the doses on the weight. And all children with severe acute malnutrition must be admitted to a hospital is also wrong, as said several times. If the kid does not have a medical complication and does not have any edema and is eating well and is alert, the child can stay at home and receive its treatment at home. I will now pass over to my colleague, Geraldine, for any questions and answers. And I've seen already a couple of questions in the chat box.
Thank you very much, Caroline, and thank you, Yvette, for the earlier presentation. Yes, we do have questions. So I'm going to jump in now with a set of questions that are not exactly the same, but are around the same thematic, which is the discrepancy between MUAC and weight for height. So what do we do if a child is green MUAC, but has a weight for height, for example, below -3? It does exist quite a lot. And what about like a mother who feels like her child is really malnourished, but MUAC says is fine? So can you, I don't know, Caroline or Yvette, between you, who wants to start to respond to this?
Yvette, do you want to go first, or?
Go ahead.
Okay, well, so first of all, a child that has one diagnosis of acute malnutrition is acutely malnourished. Okay, so if the MUAC is red, or the weight for height is less than -2 standard deviations, no matter what the other criteria are saying, that child is malnourished. Okay, so if one of the two says the kid is malnourished, count it as malnourished and give them treatment. Because the research has shown that the criteria are independent, but both are valid. Now, the other question was about what if the MUAC is green, but the mother is nervous? As a mother, I must say that you should, and as a doctor also, you should always give credit to the mom. If the mother says, there's something wrong with my kid, there can be lots of things that are wrong. And so if the MUAC says it's green, but the mother feels uncomfortable or says my child is not healthy, that child should have another examination. And I would say, yes, there should be weight for height. There should be, very importantly, testing edema. And there should be a very thorough exam of the child's developmental milestones, because it could be a child that actually has a neurological problem, and that will end up being a disability when it goes on later in life, but the mother is detecting it actually earlier than the health staff. And in that case, the MUAC is going to show green, but the kid is not fine. So yes, take them seriously, but consider other options.
Thank you. Yvette, do you want to complement?
Yes, actually, I think Caroline gave a really good explanation, but I would just like to insist that weight for height and MWAC are independent criteria. So if a child is diagnosed with acute malnutrition with weight for height, but no with MWAC, he has acute malnutrition. If the child is diagnosed with acute malnutrition with MWAC only, but this is not supported by weight for height, this child is diagnosed with acute malnutrition. So it's really, this is the message. These are independent criteria, and one or the other is sufficient.
Thank you. I hope, like, for the people who are wondering, it's clear now. What is the frequency of follow-up visit with the Simplify approach? Because we mentioned that we do give less UTF per child, the same product for both MAM and SAM, but what is the recommended frequency for supervision?
It can be, I mean, before COVID, it is suggested to do it minimum 2 weeks, so ideally every week, as Caroline said. But in the context of COVID-19, it is suggested to space those follow-up visits up to 4 weeks. So 4 weeks is fine, but the important thing here is to train the mother so that the mother or the caregiver can really measure the MWAC of the child and can identify any problem within these 4 weeks. So if the problem is identified at week 3 or week 2, instead of waiting for the follow-up visits, the mother can take action. I think that's the important message. And also it's important to give enough supplies between follow-up visits. So for example, if the visits are spaced by 4 weeks, it's important to give our UTF for these 4 weeks.
Okay, excellent. Yeah, empowerment of mothers and families, right? That's the key. Okay, great. We do have a couple of more questions, but we're arriving to the end of our webinar. So I will give back the word to Yvette to conclude this session.
Thank you, Geraldine. Okay, well, I would like to thank everyone for having participated in this webinar and also in this webinar series. I hope you find this information useful. We will look at all the questions that you're asking, and if we can answer to the questions or provide any resource to help you, we will do it after this webinar series. We will prepare an email summarizing, I mean, with everything, with the presentations, with the resources, with the links to the recording. So you will have all that. And of course, after that, I mean, participants who were present at the 3 webinars will receive a certificate of completion. And just for final words, I would like to say that if you have any question regarding nutrition in emergencies, please do not hesitate to contact UNICEF in your country, or also the Global Nutrition Cluster Technical Alliance at their website. Caroline, do you have any final comments or words? Up to you.
No, thank you very much, everybody, for participating. And as Yvette said, those of you who have participated in 3 webinars will get a certificate that I will be sending out. And we hope to see you again if there is another chance of nutrition webinars for the LAC region. Thank you and bye-bye.
Goodbye, everybody, and don't forget to fill in the satisfaction survey, which will pop up when you close the Zoom webinar. Thank you.
Okay, bye-bye.
Thank you. Bye.